Good morning. My name is Jude Moore. I'm a visiting fellow here at the Center for Global Development. And in my previous life, I was Deputy Chief of Staff to President Sirleaf when we responded in Liberia, when we responded to the Ebola outbreak in West Africa, and then went on to become the Minister of Public Works. So it's good to be here this morning. And I'm just going to be giving you a couple of comments before the panel takes over. When the war ended in Liberia in 2006, I remember the first budget, the entire budget of the country was $80 million. Now, $80 million, in fact, $80 million is not enough to do a single road project with the Ministry of Public Works, but that was the basis of the budget that the government created. And everything was a priority. You had to make a priority out of priorities. And so what the government set out to do was to build a health system that will accommodate, that will respond to the issues that normally arise in the country, malaria, and every rainy season we have cholera, and reducing maternal mortality, reducing infant mortality, immunization, those things, because those are the things that were normal. Those were the things that we saw more often than not. And so even when the outbreak started, we thought it was malaria. And even when we knew it wasn't malaria, maybe we thought it was Lassa fever, because that region of the world, we have outbreaks of Lassa fever. But it took a while to be able to pinpoint what exactly it was. But what I wanted to share before the panel comes up was something we noticed. Every rainy season in that region, but especially in Liberia, we have an outbreak of cholera. Every rainy season, just because of the poor water and sanitation services. But during the Ebola outbreak, there was no cholera outbreak. And I don't know yet if any studies were done to pinpoint exactly why it happened. But our working theory is that during the Ebola outbreak, almost every home had an Ebola bucket, and there was this bucket with chlorinated water. Almost every public building had Ebola bucket. So when you walked into the building, before entering the home, you washed your hands with chlorinated water. I mean, you came home from out and you smelled like chlorine. And because people were washing their hands, our theory is that it prevented an outbreak of cholera as would have happened normally. Which brings me to the point that despite the effort of the response, the healthcare workers that were mobilized from all across the world to respond to the outbreak, it was really, really the changes in the behavior of the people that drove down the infection rates. And so going forward, what can we learn from that? It's going to be great that we can have increase the number of healthcare workers. It's going to be great that we can increase the number of treatment units. But sometimes an outbreak as big as the one that occurred in West Africa, it might not be enough to have like physical tools to be able to do it. It might be the people themselves and trying to change the behavior of the people that actually helps to drive down the infection rates and changes. So with that, turn over to the panel. Thank you.
Well, hi, everybody. Thanks for coming. My name's Reid Wilson. I'm a reporter at the Hill newspaper here in D.C., and I happen to have spent a couple of years of my life writing a little book about the outbreak in West Africa. So I'm glad for that introduction, and I'm really excited about this panel today. This is going to be a lot of fun from a lot of people who were there, who understand what's happening in the global health community and the weaknesses that we all still face and that we need to address as time progresses. So I just want to start. I want to give everybody a few minutes to introduce themselves. I hope that's not me. Okay, good. Introduce themselves and tell us why they're here and their response. So let's start with you, Ambassador.
Great. So good morning. My name is Sinead Walsh. I'm the currently the EU ambassador to South Sudan, based in Juba. but was during the Ebola crisis, and for 5 years in total, the Irish ambassador to Sierra Leone and Liberia. And my co-author of our book, Getting to Zero, might introduce himself.
Hi there, my name's Oliver Johnson. So my background is a medical doctor and a health systems researcher. So from London, and so I was in Sierra Leone for 3 years, working on a health system strengthening project for Kings based in the main government hospital. So found myself there when the outbreak started, and then became quite involved in some of the response, and then following up with the book Sinead.
I'm Jeremy Konyndyk. I'm a senior policy fellow here at CGD, and previously was the head of the Office for Foreign Disaster Assistance at USAID, in which capacity I oversaw USAID's and the US government's overseas response to the Ebola epidemic.
Hi everyone, I'm Carleigh Krubiner. I'm a policy fellow here at CGD, and for the past few years I've been leading work to try and figure out how to ethically and responsibly include pregnant women in the ways in which we respond to epidemics like Ebola.
Great. Well, thank you all, and welcome again. And not to go straight back down the line, but I wanted to give. We all have some sort of introductory remarks, and so, Ambassador, why don't you two start?
I think we're a sort of a double act, so
It's very cute.
we hope you think it's cute. So you want to start?
Yeah, so I just thought I'd start saying a little bit about what my experiences were in the response. Sinead will do the same, and then we'll just talk a little bit about some of the conclusions from the book, which we think are lessons for future outbreaks or even current outbreaks. So, as I said, my background was as a doctor. I went out, I first went out as a medical student in Sierra Leone, and I went back out in 2013 to set up a small project to support the main government hospital, the main medical school, the ministry, on doing long-term health system strengthening. So my background's not at all in infectious diseases or outbreaks. And I'd been there with a small team of, I think, really 3 or 4 of us at the time, a pharmacist, volunteer, another young doctor, based in the main hospital. When, a little office up by the medical superintendent in the heart of Freetown, a big old colonial hospital. When, BBC News flash came up about this, these strange fevers, infections that were going on in Guinea. No one was quite sure what it was at the time. Then the diagnosis came through in sort of about March 2014 that this had been diagnosed as Ebola, but it was still in a foreign country. And so then I wasn't expecting to get involved at all, actually. I thought, we're a small health systems project, what would we have to do to help? But the minister called us up and said, look, I'd like you to come along, because there aren't actually a lot of clinicians, international clinicians in the country. There's a lot of people doing vertical programs on malaria and things, but we'd like you to come along. So became a bit involved initially in supporting the Ministry of Health to develop a national plan for how to manage clinical cases of Ebola. How do we get hospitals prepared so that if a patient walked through the gates with a fever, with Ebola, they can prevent infection, they can treat the patient, and so on. So initially quite involved in a kind of theoretical basis. And I think that was our window. That was an opportunity we had to get ready, because we had a couple of months when we were hearing about what was going on in Guinea and in Liberia, when Sierra Leone sort of had an opportunity to get prepared. But the reality was a lot was done on paper. Lots of fantastic policies were written. Very few of those policies ever made it out of the ministry building in Freetown to remote rural hospitals where there wasn't internet access, where there weren't printing facilities to print the policy, let alone read it, let alone actually enact it. So the reality was that when Ebola then started to sweep through the country from the east, initially in a rural area and then in a big city called Kenema, and then gradually moving towards Freetown, there was very little meaningful preparedness on the ground. And so at the same time, what I was doing clinically was helping the hospital, Connaught Hospital, to get ready. And initially we had a 2-bedded isolation unit, because we thought there was a small chance that 1 or 2 patients from a rural area with Ebola might come and present for treatment. Because at the time, there was this belief that Ebola doesn't cause big urban outbreaks, and it was sort of repeated as this mantra. No one could say why, everyone just said it was true. And one of the lessons for me is, if someone can't say why something is true, then be very suspicious of it. Because we were a bit caught up in conventional wisdom. And so then, pretty quickly we saw more and more patients arriving. Our 2-bedded unit became a 9-bedded unit, became a 25-bedded unit that ultimately saw about 900 Ebola patients in that small room. So my role was being quite hands-on, clinically involved in the response at that point, as well as advising nationally and then really getting involved in the coordination efforts. So what we began to realize is that while our hospital in the heart of Freetown was overwhelmed with patients, and we had to build a tent out the front of the hospital where patients who needed a bed could wait, sometimes for days, until a bed became available for them on the inside. There were other hospitals up the road that were half empty. And so another kind of big thing that emerged for us was actually the importance of really strong coordination. And so worked a lot with the Sierra Leone military on setting up coordination structures. So that's a bit of a sort of my background, my involvement. But I'll hand over to Sinead to sort of say a bit more about hers.
Yeah, I guess you might well wonder, why diplomats ended up getting very involved in an infectious disease outbreak. I was wondering the same thing myself in 2014. But basically, I had been in the country about 3 years when Ebola struck, and while initially I was, thinking, this is just dealt with by WHO and CDC and the Sierra Leone Ministry of Health, it very quickly became apparent that just wasn't going to work. There was a huge denial, really, of the both internationally and nationally of the seriousness of what was going on. And so all sorts of individuals like Oliver and myself, who were in totally different roles, ended up getting very engaged. My role was, I suppose you could politely say it's like advocacy, but in reality it was more like harassment, kind of just trying to get people to talk to each other, trying to push some of what NGOs and people like Oliver on the front line were finding to the policy tables in Freetown, Geneva, New York, and so on and so forth. And really, as Oliver said, this point about coordination was absolutely key. And this is really how we met in sort of kind of crisis, crisis advocacy, as it were, in those early months in Sierra Leone, trying to get people to really see the severity of what was going on. And then when the outbreak was finally winding down, 11,000 deaths later on in the sub-region and 4,000 in Sierra Leone, Oliver and I actually quite accidentally ran into each other on a beach, Tokay Beach, for those of you who know Sierra Leone. And it quite sort of, in this odd conversation that you have on a Sunday on a beach, I ended up having a sort of a 4-hour conversation about how angry I think we still were at so much of what had happened, and how we felt as though there was there was a lot of backslapping that was starting to happen, because actually the outbreak, a lot of good things had ended up happening eventually. So there was a lot of sort of self-congratulations, but those of us who were there from the very beginning, we had just seen thousands of unnecessary deaths, and we had a really hard time dealing with the self-congratulation that was going on. And so we ended up having this 4-hour conversation, and then we thought, well, it would be sort of hypocritical if we just talked about these things and didn't actually try ourselves to put something down on paper. So we quite reluctantly, I think it has to be said, decided we would start writing this book together. And just briefly, I mean, there's sort of 5 main lessons of the book. I'll mention the first 3, and Oliver, the last 2. The first lesson, and by far the biggest failure of the response, community engagement. We focused far too much on the medical aspects, but actually, no matter how many clinics you have, how many beds, how many ambulances, if people are not, really convinced that, number one, this strange disease is real and it's what the government is telling you, even if you don't trust the government, those sorts of issues, if the community doesn't actually believe that it's real and trust whoever is giving the services, then you can forget about it. Nobody's going to come to your clinic. Nobody's going to get into your ambulance. And for months and months, we didn't give this nearly enough priority, and it is absolutely the biggest failure of the response. I think Liberia did a lot better than Sierra Leone, but in Sierra Leone, we took a very punitive approach. We locked people up in houses if one of their relatives had Ebola, to see if they were going to contract it. Of course, we increased their likelihood of contracting it by locking them up with their relatives. And we did, we took a very militaristic approach. Eventually, though, we did learn some good lessons about compromise and respect and empathy. And again, we go into quite a bit of detail on this in the book. So there are good lessons, and we really are trying to help them be spread among the people currently working on the DRC response, which I know we'll get to later. The other 2 lessons that I'll mention, I mean, Oliver already talked about coordination. We have a very strong lesson around leadership and coordination. and how poor leadership and coordination was, both nationally and internationally in the beginning. And there are very kind of structural issues within the government of Sierra Leone and within the World Health Organization that really led to that. But then we also saw really unusual leadership from different quarters, from the Sierra Leone Army, believe it or not, really, really strong medical leadership from them. The UK government came in a really big way in Sierra Leone. So we saw some good practices as well. And then the last one that I'll touch on is, again, very related, politics and accountability. There was huge corruption that pervaded the response. People don't really like to talk about this stuff so much, but I'm a diplomat, so my life is politics, so I have no problem talking about it. But the politicization of the response was a huge barrier to getting things done, and the amount of corruption. Oliver, the last two, maybe?
And I mean, that's how we most memorably connected, actually, on the front line, trying to open up new Ebola units with the government, with hospitals who were asking for our support. And had the resources and the staff ready to go. There were patients queuing up outside and getting obstructed by local and international politics, and having to go to Sinead and saying, Sinead, you need to help me unblock this, because I don't know what to do. I know I'm a doctor, I can do the medical stuff, but I don't know how to work through some of these challenges. And that was a big surprise to me, and something I wasn't expecting. And links to the last two. So the fourth lesson is around working with government systems. And I think too often there's an instinct that we have to go it alone and build separate structures and do things in parallel to government systems. And sometimes in a conflict zone, for example, I think it's necessary to be separate from the government if it's part of a warring party. But actually in something like an Ebola response, it's always going to be the government, government health workers, government facilities that is going to need to be front and center of a response. And I think there are real advantages. So we were able to open up Ebola units in a week. So we'd get a phone call on a Sunday, saying, could you come and support this district hospital, set up an Ebola unit? We'd come in, we'd have a construction team working with the hospital building a tent. We'd support the staff to go into one of our sites to do hands-on training. 7 days later, we'd have a patient in that unit, fully run by the hospital with quite minimal international support, and run really safely and effectively. By comparison, something like Kerrytown, which was the flagship British Ebola treatment unit run by Save the Children, the British Army, cost £80 million. Ours cost about $5,000 each. It would involve clearing a whole field, putting in new roads, new infrastructure, starting up whole new systems. Kerrytown took about 4 months in the middle of a crisis to build. Ultimately, a year later, BBC journalists described how it was used only by goats a year later, because of course it's built out in the middle of nowhere, without being relevant to the system. And I think there are real opportunities. We were able to use DFID funding for the emergency to build a permanent centre of excellence for infectious disease at the main government hospital to cater for any future outbreak, be it cholera or Lassa or Ebola, and as a training site for staff. So I think it is possible. And finally, just around the importance of individuals. And actually, although we talk quite a lot in the book about some of the challenges, there are also remarkable stories about particularly Sierra Leonean colleagues. And part of wanting to write this book is that some of them aren't able to tell the story themselves, a lot of them because they passed away during the outbreak. But there are remarkable stories of individuals who weren't necessarily doctors or epidemiologists, but were involved in management consulting, or an extraordinary guy, Mohammed Boy Jallow, I knew as a medical student. He was a few months after graduating, working with Sierra Leone military, opened up a 100-bed Ebola treatment center. He got a call at 10 p.m. on a Friday night from his commander saying, you need to get down and open this unit by tomorrow morning. He took a patient bed, put it in a storeroom there, and lived in the unit for months on end. And someone, just to end on, like Yvonne Akisoya. So Yvonne had been living in the UK as a Sierra Leonean kind of management consultancy background. She got on a plane to Sierra Leone and said, I want to help out. Became director of planning, I think, for the national Ebola response. Then the director of the sort of recovery efforts, and was recently elected mayor of Freetown, and is doing extraordinary work there now, preparing the city for a brighter future. So I think the last thing to end on is some of the optimistic stories of individuals. Thanks.
Jeremy?
Great. So some of my research here at CGD focuses on pandemic preparedness, and the first big piece of that, which I'll be publishing a paper on in a few weeks, just as soon as I actually finish writing it. The research is done. Looks back at the U.S. and international approaches to the Ebola response to try and extract some lessons for both the future Ebola responses and future epidemic responses, but also trying to think how these lessons would apply to a much larger event. Because I think anyone who worked closely on Ebola comes away from that experience fairly terrified at how close to failure the whole enterprise came, and how utterly unprepared we were even for something on that scale, much less for something that could be much more dangerous and much more widespread. So a few lessons that emerge from looking at the U.S. and the broader international responses to the outbreak. The first is, and I think this dovetails with a point that's been made or complements it, the traditional clinical and medical responses don't scale well. So the traditional approach to Ebola was premised on a small-scale rural outbreak. You could set up a 20-bed ETU, Ebola treatment unit, and then do a bunch of wraparound community engagement activities and contact tracing and case finding, and that would kind of do the trick. That works really, really, really well if that's all the scale you need. That does not work well when you have an urban outbreak. It really does not work well when you have multiple simultaneous urban outbreaks. The largest Ebola outbreak prior to West Africa in 2014 was on the order of 500 or 600 cases. I forget the exact number. There were individual days in West Africa when we had around that many cases emerging. And what we found when we tried, the international community and the US government tried to just take that traditional toolkit and scale it in a linear way was that was basically impossible. You couldn't find the personnel. You couldn't find, the number of trained personnel to run an ETU did not exist. Normal ETU would have been about 20 beds. The US and Liberia, whether or not this was wise or not, but the US and Liberia was trying to set up 1,700 bed units simultaneously. And so you hit scale bottlenecks very, very quickly on that kind of an approach. What does scale, or what did scale, was behavior. And that means we need to invest much more, again, as has already been said, we need to focus much more on the behavioral components of disease control and not just on the medical components of disease control. And I think that was a major flaw in the initial approach to the outbreak. And as we look forward to future outbreaks, that dynamic is going to be, I think, even more apparent. If you think of an outbreak that had 100 million cases, not just 10,000 or 30,000, but 100 million cases. Think something on the scale of the Spanish flu epidemic 100 years ago this year. There is no way you could scale up a clinical toolkit quickly enough to matter. And there are no medical countermeasures that would currently exist or could be developed quickly enough to matter. So really, you're down to behavior. And that's an area that there is far too little research in, there's far too little planning in. So there's a huge gap there in our collective preparedness. I think the second is, and it builds off that first point, the second is you need a different strategy when it gets to scale. And so if your traditional toolkit isn't scaling well, you need to identify what will scale and then figure out how you operationalize that. And again, there's been very little planning done there. So there is hopefully some future research we'll be doing here at CGD looking at some major pandemic threats, looking at the tools that are available for countering those, and then extrapolating what would it look like to contain this event at 10 million cases, at 100 million cases, at 1 billion cases, and where would you hit scale bottlenecks along the way, and what does that mean for how you have to adapt your strategy. The third lesson that comes out, and building on those first two, is that when your traditional toolkit doesn't work well, you need to change your strategy. You also need to change your leadership structure. And the U.S. response to Ebola in 2014 went through, I think you can broadly say, 3 phases. There was the initial traditional phase where we deployed CDC teams, the World Health Organization deployed its teams and worked in a technical support capacity with the national ministries of health in the affected countries. And MSF and a few other NGOs and the Red Cross got involved. And again, that traditionally had been a successful recipe. This time it wasn't. And as that became apparent in June and July of 2014, and the outbreak, after nearly being curtailed, began to really explode, there was no developed plan B for what to do. So there was no sense of, okay, we should pull in a different part of USAID, we need to start pulling in the NGOs and the humanitarian agencies, and here's what you should be doing. None of that existed. We eventually figured it out months too late. And along with that different configuration of players, you need a different leadership structure. So you need to shift from a more technically oriented leadership structure to a more operationally oriented leadership structure. And so that was the shift that in the US system we made roughly the beginning of August, which was probably 2 months too late by that point. And we went with that approach for about another month and a half and realized pretty quickly that that also was not getting the job done. And so that was when we began sort of protracted move into what I think is a phase 3, which involved bringing in the US military, substantially broadening the operational footprint to a huge range of NGOs. The US ended up spending billions of dollars on this response. And also bringing in, again, echoing one of their points, a political element. Not just a political element overseas, but a political element also in this country. And you'll all, if you were here, if you lived in the US in about this time in 2014, you'll remember the hysteria that gripped the US. So the White House chose to bring in an Ebola czar, who was not an infectious disease guy, not a public health specialist, not a scientist of any kind. He was a political operator and had been a chief of staff for 2 vice presidents, a guy named Ron Klain. And that got a lot of flack at the time. There was an SNL cold open, a Saturday Night Live cold open mocking the appointment. It got a lot of flack. But actually it was a brilliant decision because what Ron was able to do, he knew what he didn't know. He didn't try to second guess the expertise of the responders and of the experts, but what he understood how to do was process and policy. He knew how to make the government systems work, which is a rarer skill than you might think, although, well, I won't comment on the current state. Anyway, it's a rarer skill than you might think, and one that I think maybe we should have appreciated more at the time. And that was really crucial because he could then make a very large-scale, very complex whole-of-government operation work while also managing some very complex politics domestically. And at that phase of the response, that was what was needed. Now, again, this was all, there's a great aphorism called you cross the river by feeling the stones. We were crossing the river by feeling the stones. We didn't know where they were. We could kind of get away with that in 2014. I don't think we can get away with it again. We need more planning. We need more systems around this. And I am very fearful as we look forward that some of these lessons risk being lost, and certainly very few of them have been institutionalized. So I think there's a lot of work ahead of us, both within the US context and in an international context to, and this is my fourth big takeaway from 2014, to figure out how we anticipate rather than reacting to these problems. So how do we monitor the trajectory of an epidemic, decide, okay, here's the threshold at which we need to up our scale. And what does that look like if we're going to do that? None of that really exists in any organized way, and that's another major gap. So there's a lot of work to do. As Sinead said, I think there is some room for backslapping in terms of the final outcome on Ebola, but a huge amount of self-criticism I think that's necessary as well for how much we missed, and particularly if we miss it again the next time, because there'll be far less excuse. Okay.
Great. So I think one of the other lessons that came out of the West Africa outbreak was that we weren't that prepared in terms of having vaccines. So in some way, we were lucky because we actually had Ebola vaccines that were on the shelf, or at least candidates, that could be rolled relatively quickly in terms of normal R&D timelines into the field for trials. But thinking about the range of various pathogens that might emerge or reemerge in the coming years, the WHO realized that we were really ill-equipped for any kinds of emerging pathogens to be able to quickly move into the field, run trials of candidates that were promising, and then deliver what turned out to be effective. So since 2014, we've seen WHO has introduced the R&D preparedness blueprint that is all about trying to get candidates into the pipeline to develop vaccines and other medical countermeasures well ahead of next emergences of new outbreaks, and to try and accelerate that pathway when we do see these emergencies so that we can move straight into the field and do efficacy trials. We've also seen there's a new institution called the Coalition for Epidemic Preparedness Innovations that is investing in early development of new vaccines against priority pathogens like Lassa fever, Nipah virus, et cetera, to try and seed that pipeline so that we're better prepared when these epidemics and outbreaks emerge. But there's a big problem here, is that the way we typically do R&D forgets about a huge population that is often very seriously and sometimes disproportionately affected by epidemics and infectious diseases, and that's pregnant women. So when we look at case fatality rates among pregnant women who are infected with Ebola, estimates range between 60 and 90%. Ebola in pregnancy is 100% fetal toxic. That means that any women who are infected with Ebola, even if they survive, which again is questionable, there has been only one case of a child that has ever survived past early infancy among an Ebola-affected mother. And what happened was when we rolled into the ring trials, there was a recommendation from WHO to include pregnant women in those trials. That recommendation was not taken. Pregnant women were excluded. And it turned out that was a very efficacious vaccine. And we're now currently deploying it in this DRC epidemic. There's been about 21,000 people that have been vaccinated using this highly efficacious vaccine, the VSV ZBOV vaccine. Pregnant women are not being included now. And this is part of a trend that we consistently see in R&D in which pregnant women, because of fear of fetal risk, are not included adequately in the kind of research that we do. And then we get to the point of deployment of efficacious solutions, and we don't have the evidence, and we're paralyzed by the fear, the specter of fetal risk, and we say, you know what, we can't include them, we don't have the evidence now. And we've seen that. I just came from Geneva last week, where there was a huge debate on the floor of the Strategic Advisory Group of experts on immunization, looking at whether or not pregnant women should be included in the vaccine campaigns that are happening in DRC right now. The focus was entirely on the theoretical risk of this vaccine, which happens to be a replication-competent vaccine, and forgetting completely about the fact that there is a woman who is carrying this child whose own health is at stake, and the harms of infection of Ebola compared to the harms of the potential vaccine. They concluded that there was not sufficient evidence at this time to change the recommendation to not include pregnant and lactating women. But the truth of the matter is that if we're not actually giving pregnant women the vaccine, we can never actually study whether or not it's safe or effective, and we'll get stuck in this trap of not having evidence and not knowing about the risk, and then out of precaution, not giving it, and pregnant women will be systematically excluded from this type of vaccine response. So what we really need is a very different paradigm, a really different way of thinking about the ways in which we research vaccines, the ways in which we think about recommendations to include pregnant women in the response. And we need to flip this paradigm or this default that they should be excluded to one of inclusion, to say, okay, show me a justification for why these women, in and of themselves, should be denied an efficacious vaccine, or in the context of research, a potentially beneficial vaccine, if the risk sufficiently outweighs the potential benefit, then that's fine. You are mitigating the risk that's associated. But we are so overly precautious and so afraid of potential fetal risks that we're willing to deny women who happen to be pregnant their fair opportunity to receive something that would be beneficial both to them and to their fetus. And so over the last 2 years, I've been working with a multidisciplinary group of experts that have been trying to really flip this paradigm and figure out in preparedness efforts throughout the R&D cycle, as well as in delivery, what needs to be done to ensure that pregnant women are not being unfairly discriminated against and unfairly excluded from all of the efforts that are going on, from all of the investments that are taking place right now to ensure that we are better prepared for future epidemics so that they're not consistently and continuously and systematically excluded from the response.
All right, thank you. That was made it through most of my questions here, so but I'm gonna ask 20 minutes or so of questions, and then we're gonna open it up to you. So if you've got questions, we'll have some microphone runners in the back. Just jot them down so you don't forget them. And I wanted to set the stage a little bit too in terms of what's happening in the DRC right now. The outbreak, as of the last update, has infected 267 people. 170 of those have died. It has spread across 2 provinces in DRC, North Kivu and a neighboring province called Ituri. And I wanted to ask a little bit about that. This is now the second outbreak of the Ebola virus this year in the DRC. The previous one happened in Equator province over in the western part of the country. And in both of those cases, Ebola has moved beyond its sort of the epicenter to infect people in multiple communities. and obviously the same thing happened in West Africa with the cases spreading through 3 countries. What is it about these outbreaks that is now spreading across multiple cities, multiple towns, multiple provinces even, when earlier outbreaks in the DRC were largely contained and did not spread in the same way? Is there something new that's happening now?
Well, I think one of the big differences both with Equateur and now with this one, Equateur, the outbreak earlier this year, the town where it initially began was a small town, but it was connected by river to some much larger areas, and so there was a substantial fear that it might travel that way, and indeed it did. A few cases did reach larger cities along the river, but that was anticipated, and they were contained fairly quickly. With this one, the town of Beni is a sizable town. There are huge numbers of people in these provinces. So, a lot of the previous outbreaks had affected either smaller towns or quite rural areas where it was just harder for the disease to travel. This outbreak in particular is affecting an area with a large population and a very mobile population because it's a conflict-affected area. There are substantial numbers, there are, I think, millions of people who are displaced internally, people who are fleeing across borders into Uganda from this area. So there's a lot more people and a lot more mobility, and that makes it easier for the disease to move.
I mean, I just say, I think, at least in the West African context, one of the things that had really shifted in Sierra Leone since the war was the road construction, the hospital construction. Well, at least the health service hadn't developed so much, but the roads were massively improved. And I was in a different part of DRC recently, but just chatting to some of the drivers there, they're talking about these new roads being built to Lubumbashi and elsewhere. So I think there is an element of physical connectedness that is outstripping some of the other surveillance systems, trust in government, effective health services. So you've got a kind of tipping of the scale, one at which, on the one side, the infrastructure is accelerating spread, but we're not corresponding in other ways with the ability to provide care or monitor it. I think the other thing I'd say is that I just think we're paying a lot more attention now, and we're talking about a lot more now. I think some of the big Uganda outbreak in particular was quite spread, but we didn't talk about it as much at the time. So I think part of it is also just the extent to which it's on our radar.
Yeah, I mean, I might just add that the one thing that's really different about the current DRC outbreak that we've never had before is active conflict. And I say this with some terror, because of course in South Sudan, which is one of the countries which could get this epidemic from DRC, we also have active conflict, and we have active conflict very much in that area that is close to DRC. It's called Ye River State. And this is actually something that Oliver and I have been sort of back and forth with some people in DRC about, because we talk a lot about trust, community engagement, we talk a lot about politics, and but what we didn't have to deal with in West Africa is the access constraints of conducting a response where your people can't get from A to B. Some of the sort of trust issues are not that different, because the outbreak in Sierra Leone, Liberia, and Guinea actually started in sort of pretty much opposition territory, particularly in Sierra Leone, and sort of groups that don't trust the government historically, and so on and so forth. So the trust issue is not. I mean, I think it's even worse in DRC, but it's not entirely new. But the issue of access and health workers actually being safe to travel has been an enormous constraint, and is one of the reasons why we are very far from being out of the woods in DRC, and then, as we know very well, in the sub-region as a result.
Can I say something on trust? Because the more I think, even following the book, about what is the foundational response, trust keeps coming more and more strongly to mind in different dimensions. And as Sinead said, there's an element of which is about the trust of the public in both the government or in international responders. In Sierra Leone, the outbreak was issued in an opposition-held area, and so there were a lot of perceptions that this was about the upcoming national census, or this was about access to resources, or this was a bioterror weapon or a conspiracy, and a lot of these actually are not, they sound like odd conspiracy theories, but they're grounded in something. That mistrust is there for a reason. This is a country that come out of civil war. So I think that was one level of trust, but there were other areas of trust that were important. Health workers in Sierra Leone didn't trust the government. They didn't trust the government to provide them with medical supplies, protective equipment. They didn't trust the government to pay their risk allowance, their hazard pay. So the doctors, the staff went on strike. The government didn't trust each other. So we had people in the ministry saying that they were reluctant to sign off, even when they had money in ministry, on their colleagues' payments because they were worried about accountability issues coming back on them. Trust between the international community giving money to the government for the response. So I just think this issue of trust or mistrust is a very toxic thing. And there's lots of different dimensions where trust is a challenge, but where there isn't trust, I just think it's very hard on any level to kind of mount a response. I don't know if that's, from coming at it from a sort of donor perspective was also your...
Well, I think we saw huge differences in, I think both the trust and what that meant for how different interventions proved effective. So in Sierra Leone, in Guinea, no, the other one, in Liberia.
Third time lucky.
Yeah, exactly. So in Liberia, USAID worked with an organization called Global Communities. A few folks from there are here today to set up burial teams. And and that was a very effective intervention. One of the reasons it was so effective was because Global Communities built that program on top of an existing set of community interventions. So the burial teams then were mapped right into the community where they were working, and the communities owned them. So those teams were not seen as some foreign imposed thing, but they were owned and managed and led by the community members themselves. And that gave them a credibility and also an understanding of the context at a team level that I think wasn't so much replicated in Sierra Leone and Liberia and in Guinea, where those teams were not built on some sort of existing program infrastructure, but were just built from scratch. And so I remember having conversations with my counterpart from DFID about strategy, and we would talk about once a week on the phone and just compare notes. And their approach, so we would say to them, we think these burial teams are proving really effective, you should go hard on burial teams, and so they did. And it didn't have the same immediate impact that we saw in Liberia. And I think it was because of partly these trust factors, partly the design and how the design of the program affected that. And so in Sierra Leone, ultimately, they had to do much more on the medical side and scale up isolation to a much greater degree than we ended up needing to utilize in Liberia, because in Liberia, a sort of a tweak in the difference in the program design led to a much more effective community acceptance of that intervention.
But also the government's the government's shift.
Yep.
I mean, the Liberian government also started off on the same kind of track as Sierra Leone and Guinea, and this sort of punitive approach. And there was this horrendous situation in a slum in Monrovia, and in West Point, and cordoned off, and police everywhere, and so on. And then the president just said, "I was wrong." I mean, how often do we see this from many of our presidents, I was wrong, and completely changed the strategy to be about community ownership. And we did not get there in Sierra Leone or Guinea. And Tom Frieden, who many of you will know, who was the director of CDC during the outbreak, when we interviewed him for the book, he said, I think the quarantine policy in Sierra Leone added 6 months to the outbreak. 6 months is thousands of lives. So, I do think the Liberian government needs to be, and since you're here, commended for that. Because it's not easy to change your strategy and admit that you were wrong, but it was really significant.
Well, and I think that captures something that was really essential to success in Liberia, was that there was an excellent interface between the international support and the Liberian policymaking process and Liberian leadership. And so every week, and Jude was in a lot of these meetings, every week President Johnson Sirleaf would convene what she called the PACE meetings, the President's Advisory Committee on Ebola. And she would chair that meeting, her senior leadership would be there, and then the senior leadership from the US and from the United Nations and some of the NGOs would be there. And so it created a high-level political buy-in, and it meant that if a decision needed to be taken, that decision could be taken, and it could be taken quickly. That was not the case in Sierra Leone, and definitely not the case in Liberia. Or in Guinea, goodness gracious. And so I think that was really, really key to the success. One other factor that I think was important in Liberia was that the disease flared up so quickly in June and July, and there was a fear factor that made that made people more willing to do things they wouldn't have otherwise done. And so if your choices are traditional burial or a safe burial team, you mightn't be so inclined to do safe burial. If your choices are mandatory national incineration of all corpses or a safe burial that you as a family can still have some sort of a ceremony around, then that's a more appealing alternative. So there was a fear that created more of an openness for behavior change in a way that, particularly in Guinea, never really existed because it never flared to the same degree in Guinea that it did in the other two.
Carleigh, let me bring you in here. The vaccine campaign in North Kivu has so far reached, north of 28,000 people, if I remember the...
I think it's closer to 21,000.
21, excuse me, I'm sorry. And then thousands more in Equator province as well. What can we say so far about the efficacy of the vaccine?
So we have pretty good data on the efficacy from the Guinea trials. The acceptance, which I think gets into this issue of trust, has actually been quite high. And I don't know enough about, is it that we have data on it at this point? This is not a trial, this is a campaign. Is it the way that the MSF and other implementation partners are actually rolling out the vaccine? But what I've heard is that vaccine acceptance among those eligible to receive it is around 90%, which is quite high and is very reassuring. Now, the challenge right now is really the contact tracing, because it's still a ring vaccination strategy, contacts of contacts of contacts, and the access issues are really challenging to actually go and find any people that may have had exposures or are part of that ring that need to then be offered vaccine. There had also been days where there was violence, where basically contact tracing stopped completely, and we saw surges of new cases in those instances. So, I think trust is 100% key, but there's a lot going on right now to try and effectively deliver vaccine. It is still an experimental vaccine in the sense that this had efficacy trials, but is not licensed. And that also complicates the picture because right now the WHO basically has what's called expanded access or compassionate use protocols that require the same type of consent procedures and approaches that you would have if you were doing a clinical trial. So that has slowed the teams down, though they've still very effectively been able to reach upwards of 21,000 people. So it's a complex situation, but generally, at least the trust in the vaccine has been higher than maybe we would have suspected given sort of broader distrust in the region.
Can I ask a question just on the vaccine? So, I think there's one component which is around vaccinating the public or contacts, but from the perspective of someone who was a health worker and trying to support Sierra Leonean health workers in the response, so, there was profound understandable fear amongst Sierra Leonean colleagues about treating Ebola patients. They all thought I was vaccinated. This was before the vaccine had been trialed because they said, you must be vaccinated. We know you're white, you're foreign, you must be vaccinated. Give us the vaccine too. And that was a trust issue. I had to try and convince them I'm really not vaccinated. But I think we, from about June 2014, we never managed to convince a Sierra Leonean doctor to work in our Ebola unit. There were some fantastic nurses and cleaners, but no Sierra Leonean doctor would go in. And a lot of that was a very understandable fear about their safety. I was quite surprised to read recently that there's still quite high numbers of health worker infections in the DRC, because I had kind of imagined that those days were over with the vaccine, that at the very minimum all health workers would, in the province would very rapidly be vaccinated, but also that it would shift the confidence that Congolese health workers would have to be on the front lines of either the response or the front lines of normal health care, providing, for maternal care and pediatric vaccines. So how much has access to vaccines, why are there still health worker infections, but also how much has that shifted the confidence of Congolese health workers to be part of a response? Do you have any kind of insights?
So I know at least the strategy is very much focused on, in addition to contacts of contacts, health workers, especially because they can amplify the infection rate among those people who are then seeking care. I don't know specifically what the acceptance of vaccine has been among Congolese healthcare workers, but again, I would assume it is quite high. I don't know why we're still seeing that, unless it's just that people are spreading.
Some of the deaths that we have seen have actually been from individuals who have said no. That's maybe a small number, but so there is that, which again comes back to trust and relationship with the government and. A lot of these health workers haven't been paid. We it's all sort of ding, 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 when I hear about these things in Congo, it's all the same stuff that we saw, health workers risking their lives every day and haven't gotten their salary maybe in, 6 months or something like that,
Jeremy, one of the things that you told me when we sat down a few years ago now that struck me as fascinating was that USAID and CDC had historically not worked very much together. And there were sort of two views. One was the humanitarian response. One was a more sort of infectious and epidemic response. Yeah. And you said that that had changed. I wonder if you all have seen sort of similar evolutions in how these big government and international organizations see themselves. Are they more operational? Are they more strategic? Are they working more across lines that previously were unbreachable?
So I'll talk about two elements of that. First, I think where you've seen the most success since 2014 is probably in the internal reforms in WHO. We still have a long way to go, but WHO had a real period of soul searching and some externally administered beatings as well from its member states following the Ebola outbreak, and that led to a really extensive internal overhaul. And so they took, believe it or not, prior to the Ebola outbreak, their emergency response section and their outbreak control section were totally distinctly managed and separate parts of the organization. And so the outbreak control was really science, and it was not operational, and they didn't think to put those things together. Those are now merged. So major internal restructuring there. They have gone on a substantial hiring spree. They have really changed they've vastly improved their communications around this, their information management, their operational capacity. There is quite a ways to go, but they are much better prepared for this than they were a few years ago, and it's because of this this core insight that the disease part and the operations part need to be merged and need to operate together. Within the U.S. context, this was the first time that the CDC and USAID emergency response had worked together at scale. So AID and CDC had worked together extensively before in the context of the PEPFAR program to combat HIV, and that was famously contentious. There was a lot of bad blood between AID and CDC because of that, and I don't think I'm talking out of turn there. It's pretty widely known. That was not the case here, and I think it was because roles were clearer and we weren't competing for the same money, neither of which are true in the PEPFAR program. But we worked together very well. Tom Frieden and I then sat down after the outbreak and said, how do we institutionalize this? And we got a process rolling. I'm not in government anymore, so I can't speak firsthand to where that stands. I think it probably has lost a bit of momentum because anytime you have a leadership shift, that risk happening. But there are still, at a professional level, they're still trying to take this forward within the two agencies. I'm a bit concerned, though, that some of the urgency perhaps is not there anymore. And I look at what's happening now in Congo. So there is a USAID DART team, a disaster response team deployed. There is CDC deployed alongside that, but they're sitting in Kinshasa. They're not in Goma, much less in Beni. And there are very valid security reasons why the embassy is nervous about forward deploying them. But I think you also need to look at the trade-off of keeping them in Kinshasa, where they are literally on the other side of the country from where all the action is. And it almost, I won't say they can't do any good there, but I do really wonder why there's not a more aggressive effort to forward deploy them a little closer to the outbreak itself.
Just on that, I think there seems to be two parts to this. There's a technical element, but there's also a political element. And I think I was speaking to one of the people who led the UK response recently. He said, look, if the same thing happened again now, we would be in much, much bigger trouble because we've learned some things technically, but the political will globally to tackle problems like this has really shifted. And certainly in the UK, we've had Brexit, since new Prime Minister, Brexit, the mood and the confidence to take big risks on the international stage has really shifted. And I wonder, the sort of running into a burning building mentality that people talked about at the time is, we need to go to the source of this problem. It's, I think I guess my question really is to others is, as much as we might have made technical progress, is there an anxiety that we haven't got the political will to take the risks we did and to put ourselves forwards, and that might be a more significant issue, perhaps.
But also, there were so many risks that we didn't take, and I think one of the big themes in the West Africa response was this sort of inequality between, what a Western life is worth and what an African life is worth. And when Joanne Liu, the head of MSF, went to the UN in September of 2014 and for the first time in MSF history said, we need the military. I mean, for anybody who knows MSF, I mean, this was an enormous sort of, kind of cultural shift. And she meant we need the scale of government militaries from the West to come and treat patients. And she got the military, but not to treat patients for the most part. I mean, in Sierra Leone, the military came and were doing engineering and all that kind of thing, but then when it came to treating patients, they were saying, no, that's for the NGOs. And so even then, and it's not surprising, obviously, every organization will look at risk and all of that, but what we're seeing now in CDC, which I know from CDC friends is so enormously frustrating for people sitting in Kinshasa who really want to be who are prepared to take the risks. But we do see this very, very risk-averse culture in our public systems, and I think fundamentally it does come down to how we value human life and how we value our lives and how we value the lives of the people that we are supposed to be helping.
On that military piece, I think there is a bit. I think it's important to just be clear on what the military was and wasn't being asked to do and what they could and couldn't do. So it was not as though the military had armies of disease specialists sitting on the sidelines that they could afford deployed to staff the Ebola units. And that's what MSF thought existed and was asking for. It did not, in fact, exist.
You didn't need infectious disease specialists, though. I mean, they had clinicians, right?
Yeah.
I mean,
but they didn't have.
Oliver wasn't an infectious disease specialist.
They weren't necessarily any better positioned to send them out than what we could generate through the NGO community. And I think actually, so there were a number of, we had these ferocious debates within the
Maybe in the US context. I think the UK context was a bit different.
I think the UK context is a bit different. Well, in the UK context, you also have a national health system, which we don't have here.
Exactly.
So there's, there is a government system that you can draw personnel from that didn't exist, that doesn't exist in privatized US healthcare. But there, we looked at a number of options for how to operate these clinics and who was better placed to do it, the civilian side or the military side. And basically every time the civilian side was better placed to do it. So I think there were some aspects of military risk aversion in terms of their refusal to do some of the last mile logistics and so on that I think were indefensible. But on the medical staff piece, I don't think that they were well positioned to do that. And had they been the only viable way to get that done, I don't think that the president would have hesitated to pull the trigger, but they weren't, and they weren't particularly suitable for it.
Yeah, I mean, our point is in the Sierra Leone context where we were basically told that they wouldn't do it, even though they could do it.
As perspective, so MSF didn't come to Freetown until mid-November, so sort of, 8 months into the outbreak. MSF came. Before then, it was me and a couple of guys from a university in London, a small 10-bed clinic from an Italian surgical group. WHO wasn't doing any clinical work. Save the Children wasn't there, so there was nothing. And when the British military did open up a unit, I think it had about a 20-bed unit in Kerrytown. I think they saw a total of 40 patients over about a year. Whereas in our 20-bed unit, we saw 850. And so they, when they asked about it, they said, look, well, we want to minimize our exposure. They did see some Sierra Leonean health workers. Some of that was compassionate and some of that was political, and some of that was because they wanted to get some experience with Ebola in case a British soldier got infected. They didn't want the British soldier to be the first patient they had experience with. But there were empty beds sitting there day after day in Freetown because the British military didn't want to increase its exposure. And I don't know when, with the US military, but when people say to me, well, we weren't the best suited people, I was not the best suited person. That's for sure. They were better suited than I was. Yeah. So I think it's a cop-out, and I think it is due to sort of, how much we're willing to stick our necks out and to shift the burden of risk onto others.
All right, let's open it up to questions from the audience. We've got a couple of microphone runners. Let's start right here. This young lady.
Hi, my name is Nina Karishuli. I work with Booz Allen Hamilton, and we work with Department of Defense actually for the Cooperative Threat Reduction Program. And I have pretty much the hands-on experience in 40 different countries working on emergency preparedness as a sideline of all our main work. So the question actually, it was, first of all, thank you to all of you for a very interesting conversation and remarks. I want to talk a little bit about the military involvement, and you kind of alluded and talked about a military role in during the outbreaks. Many countries I visited and many governments I talked, military is never invited at the table during the peacetime. So the remark what I was trying to make here, whenever we are talking about emergency preparedness, CDC or equivalent of the National Center for Disease Control, any organizations, they are always invited around the table to talk about the emergency preparedness. But think about one thing, police, national security, military always are left out or marginalized, so sort of like kind of orphan child during the peace when we don't need them. However, when the time comes, everybody talks about, oh, military has to move in. And I know firsthand that military did want to move in, but they also do not have the forces to deal with the mega outbreaks like that. However, in some of the countries, military is only resource, like Indonesia, to go and attend to disasters and earthquakes and whatnot. And that's also the emergency in that situation, and it's only military who goes in. So my question to you is like, what are the recommendations or thoughts or lesson learned? How would you open the doors for military to come in and sit down with the civilian agencies during the peacetime? That's a time when we need to prepare, not a time when a disease strikes or any disaster.
Anybody want to address that?
Yeah, I mean, I think it's mainly to agree with you. I mean, the whole point of preparedness is obviously that you try to replicate, the actual situation, and then you don't sort of turn around at the last minute. I think for us, there were some extremely positive, impacts of both Sierra Leonean military and the British military, notwithstanding what we just said, that we would have wanted them, to be able to do more. The Sierra Leone military absolutely came in clinically with no preparedness and probably no involvement in preparedness, although now there's a new preparedness structure that they are, that is being led by the Office of National Security, and they are now involved. So that is a good lesson learned. But I think the Sierra Leone military was actually the one institution that in the public sector that really stood up and it deserves huge credit, and which came, I think, as a surprise to a lot of Sierra Leoneans, and is actually also down to, in part, a huge amount of capacity building since the end of the war that the British government and the Americans and others have put in. But I think just on the British military side, I mean, one enormous positive impact for us was just the discipline and the order and the straightforwardness of working with some of these military guys. I had some, as it happened, I had some Irish military come to boost our response, and I used to try and say to the rest of my staff, look, I asked them to do things, they do them, what's, please, take note, which made no difference whatsoever. But that kind of straightforwardness, and give them a job, and they do the job, and not so much maybe politics as we civilians tend to bring into things. But I mean, Alva, you worked very closely with.
Yeah, no, I'd echo all of that. I think one caveat I'd say is that there was a uniquely good relationship between the British military and the Sierra Leone military, and I suspect between the American and Liberian militaries, because of their involvement in rebuilding those militaries after the Civil War. There was trust there. There were British military officers pre-Ebola embedded in the Sierra Leone Armed Forces in the office of the Chief of Defence Staff. A lot of Sierra Leone officers have been to Sandhurst, the British military academy. I don't think the French military could have gone in. I don't think they were or could have gone into Guinea.
No,
politics there. No. So I think if you look at in terms of what is replicable in other places, there was something quite distinctive. My impression. I defer to others about those relationships that would be very different in a lot of other countries.
I think that's absolutely right. And I think that's a huge caveat on any discussion of military roles in outbreak control globally. It is, as you say, a very unique historical relationship between the U.S. and UK militaries in these two countries. And there are probably relatively few countries in the world that would be as welcoming to a U.S. and or UK military deployment for this kind of an effort. Mm-hmm. So if this were happening in South Sudan, if this were happening in anywhere in the Middle East, if this were happening in most of Asia, you could not imagine a large-scale Western military deployment. And so we should not be too reliant on a presumption that in the face of a global epidemic, any kind of global military deployment will be accepted or have a role to play. We really need to build out the civilian tools. And at a local level, I think it depends. I mean, I think your point is more about national militaries and their role in disaster response. That needs to, if that's going to be part of the response, it needs to be built into the national planning, and particularly understanding the risk and how they engage with that risk. And that was, for the US military, a really substantial impediment. So, the US military will send its troops into risks it knows and understands very readily. This was not a risk it felt it knew or understood. And so, perhaps when you asked the Irish military to go do something, they would go and do it. When we would ask the US military to go and do something, it would go back to Washington for 3 weeks of policy consultation in the Office of the Secretary of Defense before we got an answer yes or no. And that was because they were very nervous about the risks to the force. And they were very nervous, and they weren't the only ones. Congress was very nervous about the risks to the force. And a lot of the red lines on what DoD could or could not do were actually coming in part from congressional political pressure not to put troops in harm's way. Now, they didn't mind putting CDC and USAID personnel in harm's way, apparently. But there was a lot of congressional pressure and interest in that. And so knowing the risk and making sure that an institution that is used to a particular kind of risk understands this very different kind of risk and how it protects itself, I think, is important to any kind of role for them.
Let's try to get one or two more questions in. I'm sorry to cut you off, but just in the interest of time. Yes, sir.
Thank you. My name is Preston Tule. I was in Liberia as a Peace Corps volunteer. I'm originated from Liberia. I returned to serve as a Peace Corps. Wow. By completing my work, I was immediately asked by USAID to do some work in education at that time when Ebola started. And because I was a Peace Corps volunteer, former Peace Corps volunteer, and USAID education worker, I was evacuated. But one thing I want to really focus on here is the fact that, like these guys, you are writing a book or have written a book. And I would like all of us here may be able to read that book. But many people in Sierra Leone, Guinea, Liberia may not have the chance to read that book. So when I returned to Liberia after the Ebola crisis, when it calmed down to continue my work as a volunteer or educator, I was able to put on some skits, have students put on skits where they can teach us or others in the country at the time what are the do's and the don'ts during Ebola or when we have such crisis. So is it a question or recommendation that we have some program, some documentary that can educate the people or the people that were really affected who survived? I know they are documentary about on survivors and workers, but actual people that were within the community, what they did, like the minister, former minister just said, the actual solution might be next time what we know not to do and to do when the next Ebola strike. So I'm suggesting or recommending a documentary that can be played in schools, young people to watch this documentary because they will not read these books. Watch the documentary so they can have a first-hand understanding or knowledge to behave appropriately the next time we have this incident, because this keep happening now, happening in the DR. We need to have that type of education.
Yeah, and this is something that we've seen in DRC as well, sort of public skits that talk about the risk of Ebola and the truth of Ebola. Does anybody want to?
I think you're just raising such a vital point. It's a much broader point. So many books about Africa are not available in Africa. It is, I think there's a really important point about whether the books are the right way to communicate and all that kind of thing. But actually, we're going to Freetown in February to launch the book, but it's already being sold in Freetown, which again is something we had to, arrange. It's not straightforward. They're not bookshops in the same way as you might hear. People can't just order the book on Amazon in the same way with no credit cards, etc. And this is something that was really, really important to us. We've also been involved in some work with one of the universities there, in Njala University in the south, and we did a sort of a poster of the key lessons of our book for the students and that kind of thing, and we participated in a conference. So just to say, I think it's a hugely important point, even just the part of your point about how books and lessons are disseminated, but obviously, and as Reid is saying as well, books alone aren't going to do it. We have to get much more visual and out there. Yeah.
I've just started working on a documentary with some Sierra Leonean filmmakers, and actually it was very much with what you're saying in mind, and hopefully doing some big screenings in football stadiums and other things. So very much intending to have that debate, because it too often happens here in DC and in London. So I totally agree. It gives me some encouragement for that project.
Let's get somebody from this side of the room. Yes, ma'am, in the back. Right there.
Address the issue of stigma related to what you've been talking about with community and community awareness and so on, because that was a very important issue both during and after in Sierra Leone.
Carleigh, do you want to talk about stigma? Is there a stigma revolving around who receives the vaccination or the acceptability of receiving the vaccination?
So I think there's actually more stigma associated with infection. I mean, because people are so desperately afraid of contracting Ebola. I will say that certainly for pregnant women, it's very difficult to actually get somebody to attend their births. So even if they don't die from Ebola, people may be afraid to attend to them, or from the pregnancy complications that can arise from Ebola infection, because there is inherently so many fluids that are happening. So it's really quite a tragic situation. I think it will be really interesting to see what happens. There was a case over the summer of a recrudescence where a woman who had been pregnant during the initial outbreak lost her child, survived the infection. Years later, after having another child, the child was fine, but then shortly postpartum, because of some interesting immunological changes that happen in the pregnant and postpartum body, her Ebola became sort of subclinical, but it was enough to infect her family members, and her husband and son died. If that is something that is more widely happening, I think there's going to be also then potentially more stigma against women who are pregnant, even in the post-Ebola outbreak period. So I'm quite concerned about that, and I'm also really just concerned about we're not giving pregnant women access to a preventive that we know is highly efficacious. We're leaving them basically to try and seek care in a context of fear and stigma, where they're not going to be able to get the kind of antenatal care that they need. And then potentially thereafter, they may have to suffer the consequences of a reemergence of Ebola years after sort of the outbreak has subsided.
I'll just add to that, there was also so much stigma around health workers, Sierra Leonean, Liberian, Guinean health workers families were afraid they would bring Ebola back in. And so, many of the people we interviewed for the book talked about, nurses coming home and finding their bags packed outside, and the family saying, look, we're afraid. If you're going to, either you have to choose continue working in the unit or don't stay here anymore. We had 3 amazing young student nurses. We didn't have any professional nurses, or only 1 or 2 willing to work in the unit. So some student nurses volunteered, but they will end up living in the hospital in a kind of on one mattress for about a year, because they were told they had to choose between what they thought was their duty and their family, and they chose to stay. But it also translated to international health workers, and many of my American and British friends, when they went home for Christmas, had sisters, or people at the border who were not welcoming them home. And actually, I think, one of when we have some slides, one of the slides we have is President Obama hugging one of the nurses in Texas who was infected, and I think he did a lot personally, visually. I didn't see David Cameron hug any of our nurses. I'd like to have done. And I think that was a really important symbolic act, but it was a really big problem.
Well, I think that gets to an important point, which is that stigma is, at a personal and individual level, it's terrible, but it's also a strategic threat to the success of the control effort. If people are unwilling to work to control the disease because of the stigma that's associated with that, then the control effort may well fail. And that in turn, I was thinking too of the example of President Obama, and in the White House following that, there was a photo of that prominently displayed. Leadership signaling matters for stigma. If leaders choose to play up stigma, if they choose to play up hysteria because they see political advantage for themselves in that, they actually are putting their own political advantage ahead of the health of the people that they lead and serve. I think it's a real credit to President Obama that he didn't indulge in that. I hope in the future we will continue to have leaders in this country who would not indulge in that. Because again, it is a threat to the success of the response, and it extends and worsens the response when that stigma is politicized as opposed to combated.
There was a group of U.S. public health service workers who came back from West Africa over Christmas in 2014, and they were asked not to come back to their community, so they spent Christmas at a hotel up in Gaithersburg.
Yeah. I was talking last week to a colleague of mine who was in Sierra Leone, and I think it was Liberia as well during the response, and came back and said the worst single part of the experience for him was the 21 days after he came back to the U.S. and the treatment he faced in this country after he returned.
Yeah. All right, we are running a little short on time, so I'm going to ask everybody to give me just a minute or two on a very small question. I know, where do we still need to get better? Where are the holes? What do we have to do now? What is the urgency now that you see? Who wants to start?
I have two very quick ones. So I think one is, I think you were asking exactly the right question earlier, when it's so much of it's become how do we prepare for the next Ebola outbreak? And I think that's the wrong lesson. It's how do we prepare for something completely unexpected that we never saw coming, that we weren't geared up for? Because I think that's actually what was unique about the situation. And I don't think we're talking about that one enough, and it's great that CGD is talking about it. And I think the second one for me is just coming back to this issue of trust, and it takes a long time. Trust doesn't just happen, it has to be built. And linked to that is trust in health services. So the long, hard work of helping governments to build health systems in these countries and build trust in government and health systems doesn't happen overnight. It requires long-term investment, but it's the ingredients with which a response is built. So really, I don't, when at the time people said we won't let this happen again, there's going to be a Marshall Plan for health systems in West Africa, and a year later, does it look any different to me as it did before? Not really, no. So we haven't kept that promise, and we need to.
Yeah, I mean, maybe sort of adding on to that, I mean, we have a tendency in health, sort of health support that we give towards, these vertical programs. We'll tackle malaria, we'll tackle, and of course, there's reasons why they're really, really important. But one thing I did when I was, because I was actually ambassador to Sierra Leone and Liberia, and I chaired the health sector pool fund in Liberia for 5 years, and it's the hardest thing I've ever done in my professional life. It was hellish. It was politics everywhere. It was corruption everywhere. The National Drug Service. It was coordinating all these uncoordinated NGOs who want to do their own thing. It was, strikes and all that kind of thing. But it's also one of the most valuable and fulfilling things I've ever been involved with in my life, because that's the unsexy, behind the scenes stuff that has to happen for health systems to work. Everybody wants to be part of the HIV program because it gets all the resources, and it's very sort of programmatic. But actually, what's your HIV program? What's your malaria program? What's your TB program without properly paid health workers and drugs that arrive on time and all these fundamentals that we don't really want to work on a lot of the time? And so I would just make that appeal for that behind the scenes, unsexy stuff that's slow and unrewarding and not easy to put into your results framework, but without which, none of the real results that we need in health systems are going to happen, and without which we will not be able to be prepared for any outbreak, much less Ebola.
You look at what has the world done post-Ebola, how have those lessons been applied. I think there are two or three big areas where a lot has been done. One is on WHO reform. One is on the expedited investments in vaccine and countermeasure development, the CEPI program that Carleigh talked about. And there's been a lot of investment in global health security at an analytical level. There's not been much money that's gone along with that yet. And so we're getting to a point where a lot of, much of the developed world has an excellent analysis of the weaknesses in their internal health security and virtually no resources to actually do anything about that. So I think that's one gap, is financing, serious financing for global health security, just as we seriously finance HIV or other global health risks. We need to stop admiring the problem and start doing something about it. The other big one, the one where I think we've probably done the least, is around envisioning what a large-scale pandemic global response would need to look like. And how would that be managed? What would the strategy be across different, you could look at that at a disease level, you could look at that at the transmission vector level, but there's been very little work done on mapping out what that should look like, who would do it, what are some of the policy and operational challenges you will hit, and then begin exercising that. One of the reasons why kind of traditional vanilla disaster response after an earthquake or a hurricane tends to work fairly well is everyone knows what their job's going to be and they've exercised that. We don't have anything like that in the pandemic space, and we need to. Carleigh?
Yeah, so I would say Ebola is sort of the poster child of how we've really done a disservice to pregnant women in the context of epidemic preparedness and response. They weren't included in the research trials. We now don't have the evidence to move the dial to get policymakers to say, yes, let's include them in the response. And in part, also the vaccine that we had on the shelf was one that's a construct that we're not all that comfortable administering in pregnancy. And I think if we look at what are the lessons, not just for Ebola, but for all kinds of emerging and re-emerging threats, now that there are being all these investments in medical countermeasures, to think, what can we do differently? How can we actually collect the kinds of data that we need when we need it, in terms of understanding the threat in pregnancy, in terms of having vaccines in the pipeline that we think use platforms that are suitable for administration in pregnant women, which, by the way, are also generally more acceptable to people that might be immunocompromised or elderly, so addresses other subgroups that may face risk with live vaccines. But also, let's be proactive about researching it. Let's base our decisions on a risk-benefit analysis rather than just on a fear of potential theoretical fetal harm. And that if we break this cycle of just kind of being afraid of doing research, afraid of generating the evidence, afraid of using effective interventions in pregnancy, and start saying, let's look proactively, let's generate the evidence we need, let's include vaccines in the pipeline that we know we feel pretty comfortable using for maternal immunization, and then let's have data to move forward so that the next time that there's an epidemic, we have vaccines that aren't just suitable for everybody else and we rely on herd immunity. We can say, look, we can give this to pregnant women, especially for things like loss of fever, which is 90% mortality and fetal harm in the third trimester. I mean, many of these things, pandemic flu, I mean, pregnant women are among the worst affected populations. They suffer the highest consequences in mortality. And we need to stop excluding them from the ways in which we're doing things from the status quo, which leaves us to just be overly cautious and basically not meet their needs.
All right. This has been the easiest panel I've ever moderated. Thank you very much, all four of you. And thank you all for being here. We really appreciate it. I love it.